Hotbed Talk.
This piece is presented in two parts. This is part 2.
Utilizing your EMR to get data. What kind of EMR do you have? Are you using that? Is it functioning well? Is it not? Cheryl, I'm going to start with you. Can you tell us a little bit? I know you have your app, but and I know you have some dashboards, but tell us a little bit more, dig a little deeper into that for us.
So let me start with our dashboard is created by our quality outcomes department. So they use very specific data that is collected for an institution, and they are able to help us with certain aspects of our data collection, such as like our glucose control. They can get us some information on that. And then we also use our Society of Thoracic Surgeons data, which gives you some metrics about your patient outcomes. That's very valuable. But we're working on the more granular ERAS elements, such as, did our patient carb load? Did our patient have the early ambulation? Did our patient have a short fasting period? So we're putting an actual paper data collection tool in place, and we're going to have it filled out, and then we will have it put into our, hopefully, STS. At some point, we want to collaborate with our STS data collection expert, the person that abstracts our charts, and have them help us get that into that same environment. So we are in the process of working on it, but the data we're reviewing now is by people that abstract charts and are part of our ERAS oversight committee and understand what we're looking for.
Okay, Epic or Cerner?
Cerner.
Cerner, I always say Cerner. Cerner, okay, great. All right, Gina?
So we are using Epic, and I just feel this pain of report. It's just such a pain because we are far from what in my mind we want. Cheryl's done amazing work with the apps and dashboard, but in my mind, I wanted an outcome report. I wanted real time on a dashboard that we could intervene before we could intervene and change that output before we got to a retrospective view of it. That was enormous for our team to build. That was really big. And we partnered with a company to help build that. But in the meantime, I need to know process elements. I need to know exactly what Cheryl said. Was the carb drink given on time, not 1 minute past? Was it consumed the proper amount? Was everything entered as far as walking, multimodal, medications, milliequivalents of opioids? And that, I went to our IT team and I said, what if I just had you develop a small, I call it the baby report. It's just the process report. And it really just speaks to those few things. Was the Ecliptin prepped, shaved, CHG, a leave-in pad, carb drink? It just speaks to those very first things. And so I get that report every day, daily now. It's just like Christmas every morning. It is every morning. Because who did that before? We all did that. We manually went into those charts and extracted that. And it comes every morning. I link it to the nurse. I send their manager. I totally agree with Vicki. When you alert and empower each leader in every division to man their tribe, you man your tribe. I'm telling you what was expected, and this is how great it is, but I need you. You can't be everywhere. I send that report with a note saying, wow, your nurses are great. Look, they did 10 out of 10 right. Or, hey, they're wonderful. They did 9 out of 10. Can you educate on this 9th component or 10th component? And then I attended myself, educational opportunities where you have to re-educate, but I can't do that all the time. So the report went from, I don't know how much compliance to almost 99% compliance just on the process. So for our team being small and IT not very resourceful, that report, until I get the big one soon, has been very helpful, extremely helpful.
Are you willing to share, please?
Yes. Desiree. And I, again, going back to our peeps, our people, when we started cardiac ERAS, I researched the whole country. I couldn't find anything with cardiac research and ERAS. And Dr. Williams, Dr. Bradford, and I, and we've promised that we would never silo this, that we wanted to share it with everyone because we are our best partners if we can just share our information. The app that the work that Cheryl's done on that app is just amazing. I want her all the time to explain that to me. But yes, we'll share everything we have. And we still have a lot of work to do. We still do too, but absolutely.
Vicki, so you're on Epic at most of the hospitals, correct?
Well, all of the main hospital system that we're at, yes. Mm-hmm. We are.
So tell us about your journey when it comes to data collection.
Yeah, so because we're actually consultants, right, within the hospital system, we're the anesthesia group contracted by the hospital. So it's very hard for me to have anything integrated. So the database that we use it has the capability to integrate with Epic, but the hospital is not very keen on that.
Integrating.
Right, exactly. And so we manually extract. And at first I was doing it. And as the program grew, of course, I couldn't do it and manage everything else. And so my group allowed me to hire a nurse to, collect the data and whatever else we can work together. And so the first person I actually hired, she didn't get the data. Like, she didn't understand.
Yeah.
I tried to teach her as much as I could, and she just wasn't getting it. So I hired another nurse, Jennifer, who I've referenced, and she's a former ICU nurse, so I love it. Type A personality, love her. Detail oriented. So she does all of our data collection, and it's really a time sucker. It is. Although I will say it helps you keep your finger on the pulse. Mm-hmm. When I was collecting the data myself, okay, I know this is a problem, so I need to research this a little bit more. But now I'm like running reports after the fact. So Gina, to your point, like more real time versus retrospective. So that makes it difficult. So manual extraction right now, I wish we had a better way. The other thing I think with data that we have not arrived at yet is there are no benchmarks for ERAS, right? Like, how do we know we're doing great? We feel like we're doing great according to where we started, for sure. Right. But how are we doing in relation to the other, across the country, the other programs? And there isn't a central database there is one in my mind. It's not that affordable, but that people can subscribe to, that everybody then has access to their data, maybe regional data, what have you, everything, of course, de-identified, that we can learn from each other. Because if I'm putting my data in and somebody out in whatever, California, and their outcomes are way better than mine, I want to know what they're doing. And so I'm going to collaborate with them to improve my program and have further discussions. We haven't gotten there.
Yeah. And Cheryl, you're using the SDS database. Is that what you said?
Well, we definitely look at our outcomes from STS, but that doesn't give you all of the granular ERAS, right. But it just kind of gives you an overview of your program and how you're doing and performing as a program. So we need to get to that granular monitoring, just like Vicki said, and have the elements that are key and then put them with our STS data, patient specific, to see which elements contribute to these better outcomes.
Yeah, absolutely. I think
we're in the process.
Yes, that's great. No, and I think, Vicki, we've been preaching this for a long time, ever since we started talking about this, I think in 2016, that, it's all about, it's not, because so many people are just so focused on length of stay and outcomes. It's all about the process. It's all about compliance from all that information. So,
yeah. And some of the worst offenders really are the providers themselves. So constant education.
Well, listen, guys, so I know we're having a conversation about the U.S., but we do absolutely have some international participants here in this conversation. So again, if you guys have any questions at all, raise your hand. We can bring you up. We're not for sure if the camera function is working, but no problem. We'll listen to your beautiful dulcet voice, and because we want an international perspective. So please be sure to ask your questions. The chat function seems to be working really well. I've been trying to keep up with EdPalm or the Slido. It doesn't look like anybody's using that. No problem. Just use your chat. But one of our international guests, and unfortunately can't see her beautiful face, but We have Kay Mitchell. Kay, are you there? Oh.
Thank you for letting me join. Desiree was just saying the international perspective. So I'm based at Southampton Hospital in the south of the United Kingdom. And my impression in comparison to the United States is that you are so much better at data collection than we are in terms of those nitty-gritty things. So you may think that you've got problems, but the way that you have to account for all of the finance means that actually you probably nail a lot more than we do. So we've got a national kind of quality improvement project going on, which is led by Ramani Moonsinghi, who you well know.
Yeah.
And it's called PQIP, which stands for the Perioperative Quality Improvement Program. And the fact that we sign up to that and we are allowed to, we are awarded money for however many patients we collect the data on does actually help us to collect data better. But I do think that you guys are in a far better place than a lot of the United Kingdom are in terms of the data that you collect related to perioperative outcomes. So that was what I was asking the question about, what those barriers are. And I think it was Vicki, were you saying how important it is that people understand why they're collecting the data? I cannot agree more with that.
Yeah.
People are so much more engaged if the work that they put in results in something that makes life better for them.
Yeah.
And whatever that carrot is, you need to, I think a carrot is always much better than the stick. And if we can just find those carrots, and it may be the outcome data, it may be that the patients just tell them that they're wonderful because, you know, they've understood the program, and it may be that that's how they get a paper out of it and feel good about themselves. But I just think it's about always trying to improve that data collection so that we can make it easier for people to collect data.
Yeah. No, absolutely. Kate, it's funny because I'm always like, oh my gosh, you guys over in the UK are so lucky because you have that. You have PQIP, you have like NELA, the National Emergency Laparotomy audit, which has turned into like kind of a bit of a quality thing. And so like you have some of those things that we don't really have over here. So the grass is kind of always greener.
I think it's interesting because, you know, when we talk about implementing enhanced recovery, and we always talk about, Gina, you said it earlier, don't want to be siloed, right? You want everybody on the same page, everybody working together, yet truly in the community, we're kind of siloed across the board. And at some point we need to get, you know, break that down and all be kind of on the same page and just work together.
Yeah. I hope that time comes.
I do too.
Yeah, me too.
So do I.
We're working hard for that. Well, ladies, anything else that you kind of wanted to talk about in your programs or your experience? Again, I want this to be kind of something that people can walk away with, you know, that it's like I learned from someone else's experience, kind of takeaway. Vic.
One thing that I think is worth saying, and I know it's hard for programs, especially if you're just getting started, but it's really important to try to have one person that really is the link to all of it and knows everything. And whether that's, you know, Gina, I mean, you were working, you know, full time in the CVRU, CVICU as a nurse. And you were doing kind of the coordinator role before they kind of branched you off and just had you do the coordinator role. And I know a lot of places are like that, but one person can't do it all. Obviously, it has to be a group effort, but there needs to be a point person almost, right? Like the quarterback that can speak to everything about it and oversee it. Because if you don't have somebody tying it all together and holding people accountable, what have you, that's when your sustainability really starts to slump. a lot of programs won't have that person early on. You can show your outcome improvements and financial improvements. Financial data is very important to look at, to say, hey, we can justify this person. So it's hard at first, but hopefully programs will get there and they can designate a person to oversee it.
I'd like to tag off that because this is the number one question, and I think we all can attest to, is how the heck do we get started? How do we start? Where do we start? And I tell them all the time, pick your one person who could lead as a champion and be the core of all those that multiple team. Choose your team wisely, keep it small to begin with. A surgeon or an anesthesiologist typically aren't going to be the lead or the champion like Vicki alluded to. It has to be someone that knows every discipline that's going to be involved and can touch those people on any day. So I pick your champion, pick your team wisely, keep it small, because once you start small and you make your decisions quick, then it's going to erupt into a multidisciplinary team that's going to be ginormous. But all those team members, even though we value their opinions and we want their research and opinions, we have to keep teams small to make those decisions and quickly. We could build an ERAS program in 6 months, or we can do it 6 years based on how much feedback we keep getting. So I love that, Vicki. I am right there with you. You have to have one point person. And even the surgeons, our lead surgeon went back to this team and he said, hey, just an example, this is what they're wanting to use for multimodal. Do we all agree? Check, check, check. He brought back to the lead person. He didn't say, oh, this is what we're going to do. We brought it back to the team. You have to have that core person. Totally agree, Vicki.
On that same thought, I have one other comment, which is I've chosen to share elements of each area with one other person, so they're intimately involved as well. So like, for example, with our app build, I had one other person that I made sure was CC'd on all the emails regarding it, so that if I couldn't continue that project to the finish line for whatever reason, that person could take it over. And I do that with everything. Like our anesthesiologist, I have a designated anesthesia person that is CC'd on every anesthesia type of related topic. And it's proven to be very, very helpful to have one person that's as involved in that area as I am, so I can bounce things off them. And when I'm not able to take over, that they can.
Man, that is such a great idea. And I think we kind of maybe sort of do that in some way, but to really to focus in on that. What a fantastic idea. Well, Kay, I want to go back to you. We've had conversations, I know we did in London, and I'm sure you guys did this morning, about the team. And we talked a little bit about it here already, but talk to us about the importance of grabbing some of those multidisciplinary team members that you wouldn't necessarily think, but could really in the end make or break a program. We talk about like getting all those people together.
I think the key thing is enthusiasm, which you've all talked about. Is about finding those champions, but it's also being, I think, really, really open to what the qualities are that those people bring. Because we work a lot with exercise physiologists. We work a lot with these individuals, which we call CTAs. So these are people who may be science graduates who are coming in, who've got a background in biology or physiology at university, and then they come in and they work in our research departments, and they come and help us run our research studies related to that sort of thing. And what happens is if you work with these individuals and you encourage them, they can move into different areas. So you can get someone who starts as a biology graduate or something, and then suddenly they've decided that they actually want to train to be a nurse, or train to be a physiotherapist, or train to be some other kind of healthcare professional. And I absolutely believe it's anyone who's got that enthusiasm who comes to the table should be encouraged. The key for me is trying to get over the barriers of funding these individuals. And you've all mentioned that again. It's a challenge of how you persuade your organization to invest in these people. And the thing that drives me absolutely nuts is the fact that a lot of these people really cost very little money compared to an anesthesiologist or a surgeon. And yet the impact they can have actually from a financial point of view and from a patient-reported outcome measure point of view is actually much greater than that anesthesiologist that they may see for 5 minutes before they have the operation and for 5 minutes afterwards. And yet, how do you convince our bosses that to invest in these people who they're the ones that make the difference to our patients?
I love it. You know, one thing that I kind of pivoting off what you were saying, one thing that as I have traveled around and talked to people kind of all over the world, really, is that you never know who you're going to run into, who could be your next ERAS lead, your next ERAS champion. And I've talked to a lot of multidisciplinary groups. And, you know, I've always been impressed when there's like an ostomy nurse there and she's like, I'm running our program. Or there's a nutritionist and she's like, I'm running our ERAS program, you know, start to finish. I'm always like, God, I love this. You know, like it can come from anywhere and we need all of those voices to really make it the best that it can be and make it work for us and ultimately the patient.
I also think, Desiree, I mean, this is an example that's slightly different. It's from, so I also work in critical care. I don't just work within research and perioperative medicine, but this is actually this is related to another piece of work that I'm doing where we're trying to increase frontline nurses and midwives to develop their own answers to problems that they have clinically on the ward and to search the evidence base related to that. And one of our senior sisters in our hospital is concerned about mouth care, and she feels that the mouth care for her patients isn't great, and we know that causes problems with nutrition, it causes problems with communication, blah blah blah, you know, healthcare associated pneumonia. But the people in her ward who she thinks are really going to be the champions to help her make a difference are the healthcare assistants, because you can give them a project and they will run with it and they will go around and they will make sure all of those nurses on that ward are stepping up to whatever protocol they decide is the right protocol to follow. So it's about finding those individuals and again, going back to the carrot idea, giving them the carrot and everyone working together.
Yeah, no, absolutely. Well, ladies, we're going to be wrapping up here shortly. And I want to end on a very positive note. We've talked about a lot of the challenges that we have, and I hope we've had a fun discussion about it. But, you know, where do we see enhanced recovery going? And I know we've touched on it just a little bit, but I want to drive some of these points home because I think we all know we're still going to have to deal with challenges. We're still going to have to deal with barriers. There's still things that we're going to, you know, on a daily basis, you know, have to figure out a way around. But there's a lot of, you know, the future is bright for this. So, you know, where do you see ERAS beyond 2020, beyond this crazy year of COVID, you know, and taking into account, you know, the journey of where we've been and kind of where we're going forward. And Gina, I'll just start with you.
Yeah, I mean, I think we're just beginning. I think I mean, you look at Vicki, who has 19 well-oiled, you know, pathways.
Well,
I'm so in awe of her.
We have our challenges.
I know. But many of us are really just getting started. And for those organizations that are just starting, like we have so much to share and we have so much to learn as well. So in 2017, I thought ERAS was just day of admission till discharge. Within that first year, I learned so much about prehab and how we needed to touch those patients. I think we're just beginning, and we're going to find these tools, whether it be the app or resources or the care provider, the patient assistant, like Kay was saying, we're going to find those resources and they're going to build this program even better. And I don't even know what the end looks like. I'm so excited. I think we are going to go so far with this. It's just exciting. So.
Yeah, absolutely. So Cheryl.
I agree with everything Gina is saying, that we're just kind of starting to feel our way, especially with cardiac surgery. But I think that we're going to be looking in the future at ways that we can optimize our patients pre-op for an open heart surgery. Maybe some work around different medical conditions that are like anemia optimization, things like that. And then I think intra-op, there's a lot of things for cardiac surgery patients that are going to be explored in the future. Best practices around anesthesia. Regional anesthesia is relatively new in this field. I think we're going to see more and more exciting things come out about that. I think that cerebral perfusion in the operating room, best practices, we're going to be starting to see more info on. And I think post-op, we're going to be embracing more and more of the telehealth and patient engagement. I'm hoping that we'll have more collaboration between places that are practicing ERAS so that we can start to benchmark against each other when this data starts to be pulled together in a uniform fashion. And I would love to see more collaboration between ERAS coordinators. And I hope I can be a part of pulling some of that together in the future. So I think it's very exciting to be a part of this at this time.
Yeah, absolutely. Vicki?
I think that, obviously we are always going to be evolving, because if we're doing the same thing 6 years, 6 years from now, 10 years that we're doing today, then we're doing something wrong. And aside from all of the technological advancements and, various things out there, I think that we are going to end up being more collaborative, because I think if we continue to have discussions like this and bring people along with us, eventually it's going to happen that we are a much more collaborative community, if you will, across our country and really around the world. I do think we'll get to a point where we have a central database so that we can benchmark. I think we need to benchmark. I think for, the local progression and evolution of things, I know that we've had a challenge with having everybody know the pathways, the protocols, and we have paper in binders, which is ridiculous, because how often pathways are updated, they all do. So, what technologies can we even, just for that simple thing, make it better for our team? And I actually have to show you something. And I'm shouting out here, again, I'm going to say Jennifer's name. And it was actually a 13-year-old son that put this together for us. It's an app. It's a QR code that you then save on your home screen. And so I don't know if you can see this. Can you see that?
No, not too good. No.
Yeah.
If you could just share screen
so, yeah, I wish that we could too. But on this, you scroll down and there's every single pathway. And when you click in it, it will give you the full pathway if you want. But then it also breaks down, what are the anesthesia orders? What are the surgeon orders? What does nursing have to think about? And what are their responsibilities? And then, they can contact us, reach out. My contact information, Jen's contact information is on there. But we're transitioning from somebody running from OR to OR, looking for a pathway because it went missing in one, to trying to really condense things and make it easier. And I think that will help our compliance. So that's just a local evolution of where are we going to be, just continuing these small steps of wins.
That's super cool. But is anybody like nurses, PCA, anybody, if they have that QR code, they can look at that? Yep. They can look at it. And we will tell them, save it on your home screen, and it's always there as an app, and you can name it whatever you want, but it's always there. Can we get the app, Vicki?
Yeah, simple
Awesome.
and free.
That's
Simple
awesome.
and free.
And free. Is it in the App Store?
No. You have to create it. Yeah,
Oh, okay.
I can talk to you more, but yeah, you have to create it. Jen's 13-year-old son did, and then Jen continued on the creation for us. So anyway, but
awesome.
super easy. Mm-hmm.
Yeah, that's great. Well, ladies, I can't tell you how much I really appreciate you taking the time to do this. Okay, you're still up here. So the international perspective, you are it. Tell us the future of enhanced recovery.
I don't know whether you talked about this because I missed the beginning of the session, but I think the key is patient front and center. I want us to be in a situation where our patients are coming and challenging us and saying, I want you to give me the tools to help me have a better operation. Rather than us driving it, I want them to be driving us to step up to the mark.
Amen, Sister K. I love it.
Yeah.
And in case you don't, she is my sister, my soul sister. But over in England, they call them sisters. Nurses.
They do.
Yeah. No, that's great. So, and just, I don't want to talk the whole time, but I do think that what I see as the future is really pushing the limits on the evidence that we're creating from this, and I mean that in several different ways. One is that I really, really hope that anybody who's doing an enhanced recovery program out there and who has seen success, no matter how small it is, but you're doing it and you're doing a full program, that you can have the opportunity to share that with other people. And I know we've kind of alluded to that, but I mean, I want some way that if there's a nurse or a nutritionist or a pharmacist or whoever who's never really written anything before, that there is somewhere that they can publish what they've done and share that with the world. And it may not be the most perfect data, and it's not a randomized controlled trial, but it's sharing the quality improvement programs that they've done. So that's kind of one, I see that. I know that it's just, we're on the precipice of that. And I think I implore the people here on this call, please take this out wherever you are, to nursing organizations or whatever, or any organizations, to continue to share our experiences in whatever way. Also, I think there's so many opportunities for each of the different elements to continue to move forward. So, I come from an anesthesia background, and there's a lot of, anesthesia providers here, but it's, making sure we're really pushing goal-directed or better hemodynamic management. I touched on it earlier. We're going to be having to report our quality metrics on that soon. Making sure that we're doing everything that we can to reduce opioids. But here's a big caveat to that. So many people think, well, in anesthesia, part of our ERAS program is that, we do multimodal pain. Well, that doesn't mean anything that if that is not continued through the continuum of care, that in PACU or post-op, you cannot give any narcotics. But if the patient needs it because you didn't do it great, or they don't have their ERAS protocol, their little box of this is how we manage pain post-operatively, it doesn't matter, because they still end up getting the narcotics. And if you don't talk to the surgeon about not sending those 80 Norcos home with the patient, it won't matter. So making sure that whatever you're doing, you're continuing it through the continuum of care, and that that everything that you're doing has making a difference, and that you are personally looking at your outcomes, as different providers. I think those are big things. And again, that's kind of anesthesia perspective, but we could talk about it all day long, and PAT and pre-op, PACU, and post-op. We all have our issues. Yeah. So, well, again, any final words? I want to make sure we have just like 2 minutes. Anything else? No. Go.
No, it's been great. Thank you for having us.
Ladies, thank you.
Yeah, thank you.
Yeah. All right. Well, until the next time, until we can be together in a room, until we can be on a paper together, whatever it may be, hold steady in what you're doing. You are doing amazing things, every single one of you. And if you have any questions, I know all of our panelists are happy to share any of the information that was shared today. I think Vicki did get that reference up for the nudge. I know we're all looking forward to that. And cheers. Have a great
Cheers.
day.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.